All right. Well, good afternoon. My name is Ashley Mangum, and I am the project manager for Kids Mental Health Pierce County. And if this is your first time joining us for today's webinar, our webinar today will be featured on inpatient hospitalization. And if you're not familiar with Kids Mental Health Pierce County, we are a community collaborative that is aimed at streamlining and coordinating behavioral health services for kids here in Pierce County. We are dedicated to developing a coordinated and responsive behavioral health system that serves the needs of children, youth, and families at the right time in the best place and with the best outcome for every family. Since the onset of the pandemic, Kids Mental Health Pierce County has hosted a series of virtual webinars with the goal of helping parents and caregivers understand and support kids and families during the pandemic. Today's webinar features an overview of inpatient hospitalization and features providers from Tacoma General's Adolescent Behavioral Health Unit, as well as an overview of children's long-term inpatient program. Anytime we have our webinars, we always want to provide a form of community support where we can also learn from each other. So we will definitely have the opportunity for questions and answers, and you can use your Q&A button at the bottom to submit those questions at any time. Also, utilize that chat box. We want to build community here. So take the time, introduce yourself. If during our presentation you have your own ideas or recommendations or strategies that you've learned, please share them as we all can learn from each other. And again, with your questions and answers, we will do our best to get to them. And if we're not able to get to them, we'll try our best to follow up after today's webinar. Because we do have limited time today, I ask that if you have case-specific questions, that you submit your questions via email, and I can forward them to our panelists who may be able to assist you with your specific needs. We will be recording today's webinar, so we hope to have this recording as well as any other training materials uploaded to our website, kidsmentalhealthpiercecounty.org, for you to share and to review after today's training. So I'm really excited today to have our panel of experts. First, we are going to hear from Tacoma General's Adolescent Behavioral Health Unit. If you're not familiar with the Adolescent Behavioral Health Unit at Tacoma General, it is the first and only inpatient program in Pierce County designed specifically to help teens facing mental health crisis. The ABHU is a 27-bed hospital-based unit. The ABHU has a collaborative team of pediatric and mental health experts, including a medical director, psychiatrists, psychiatric advanced registered nurse practitioners, mental health technicians, social workers that are working together to create a treatment plan tailored to each teen's needs based on their diagnosis, backgrounds, and triggers. So I have the absolute pleasure of introducing Dr. Tanya Kellerman and Dr. Bhutia, the psychiatrist and medical director for Tacoma General's Adolescent Behavioral Health Unit. So I will turn it over to our speakers, and thank you.
Hello, good afternoon. I'm going to, do everything wrong, and I'm going to share my screen. My name is Peggy Entrop. Here we go. All right. So I'm Peggy Entrop. I think I have, there we go. Our names up here. I am a licensed clinical social worker and the program manager at MultiCare's Adolescent Inpatient Behavioral Health Unit. And I'm joined today by Tanya Kellerman and Dr. Bhutia. Ooh, and this is a good example. We are in hospital today, so you may hear some very distracting background noise, and I apologize ahead of time. If I could make it go away, it would be a miracle. Sorry about that. Hopefully you can hear me. I tend to have a booming voice. Today we're going to talk about a few things. A little bit on the agenda is an overview of the psychiatric hospital admission process, an overview of our unit here at Tacoma General, a little bit about our therapeutic goals of inpatient care, and information about the role of medication in psychiatric inpatient treatment. So what is psychiatric hospitalization? It is acute care for psychiatric emergencies. That is life-threatening situations where immediate intervention is required. This little, image shows a little bit of the overview of the process that I'm going to talk about beginning with the emergency room and psychiatric assessment through safety planning, maybe the failure of safety planning leading into one of 3 types of inpatient hospitalization placements that are possible in Washington State. So we'll talk about each of these things in depth here at the beginning of this presentation. So the first thing is admission criteria. These criteria are not specific to teens. They're for anybody who might be appropriate for an inpatient psychiatric admission in Washington State. And I think of them as the big 3, the first being imminent risk for self-injury with an inability to safety plan. So that means some level of danger to self. The second criteria could be an imminent risk for injury to others. So that might be a danger to others situation. The third being an acute and serious deterioration from the person's ability to manage their own age-appropriate activities of daily living due to an active psychiatric symptom. Sometimes that's called grave disability. You may hear that thrown about a bit. And because of a person's psychiatric symptoms, that means that they are having some kind of deterioration where they're unable to care for themselves. So their basic health and safety is at risk. And these are sort of the 3 imminent risk areas that are at the top of a person's mind when they're assessing folks for, do we need to think about going to a hospital for psychiatric reasons? As part of this process, this may be an outpatient provider asking questions, or it could be an emergency department, but the kinds of things that they're going to be interested in are on this list. So they may be primarily focused on immediate health and safety, but they may have a lot of other questions about self-harm behaviors, intent to harm others, high-risk behavior, changes in personality or behavior, changes in sleep patterns, changes in weight, changes in psychosocial functioning. The repeat of the word changes is not an accident, because part of what we're looking at when we look at whether someone meets medical necessity for an inpatient psychiatric admission is that there's something out of the ordinary that requires that immediate intervention. So if someone's experiencing long-term static behavioral health issues, that may not be something that a psychiatric hospitalization may be beneficial for. But if it's something that suddenly there's some kind of major change in their presentation, then providers may start looking at hospitalization as an appropriate intervention. And we'll talk a lot more about that. So the first step, well, I don't know if this is the first step. The first immediate step in getting admitted to the hospital is through the emergency room. And there's a lot of reasons for this. Sometimes it feels like if a person is willing to come to the hospital and, being in the emergency room is distressing and it's very, troublesome in some way, we look at, can we avoid that? And unfortunately, the process currently exists that it is a necessary step. And some of the reasons for that is that each patient needs to be medically cleared. And what medical clearance is a series of screenings and maybe tests, depending on what's going on, to rule out medical causes for the change in presentation. So if someone's having increased depression, they want to rule out medical causes, because then we don't want to have people in a psychiatric hospital who really need acute medical intervention. And so some of those steps can feel, I don't know how they can feel. I guess they feel frustrating sometimes if it's something that, you've seen a lot of providers or maybe been to the emergency room a few times. It can feel like an interruption sometimes, but it is part of the process. Also at the ER, they have a responsibility to provide attempts at safety planning. and diversion if possible. So they may have, depending on the area and the particular emergency room, they may have access to increased intensive crisis services that can step in to provide the appropriate level of care for someone to stay out of an inpatient unit. And if that's possible, we want to do that first. We always want to seek the least restrictive treatment possible. And so if it's possible to keep the teenagers safe in the community and support them with increased outpatient care with the family, that is a fantastic result to me, and a great reason to avoid coming to a psychiatric hospital. So in the emergency room, if the safety planning isn't able to make an appropriate safety plan to have them leave the hospital in a safe way and go back into the community, then the patient might be able to access voluntary inpatient care. So inpatient care, back on my original slide with the picture, there's those 3 types of admissions. Inpatient care on a voluntary basis is the least restrictive in the sense that it's an agreement between the patient and the hospital that they are willing to be here and that they're willing to accept the kind of care that we have available to them, which we'll talk about, may or may not include medications. It includes a lot of therapy. So someone needs to be willing to do that and willing to stay voluntarily. In Washington State, patients aged 13 or older are allowed to voluntarily enter psychiatric care without the consent of a parent or guardian. Some people find that surprising because 13 feels very young, but that is the current Washington State law. And so that is something that could be available to them. We do, whenever possible, collaborate with parents and provide notification as appropriate. But that is something that sometimes parents feel a little blindsided at times if they feel like that they're not aware of that allowance by the law. So while voluntary inpatient treatment is voluntary, that seems like it follows, it is still a hold. It is still a psychiatric hold. So there are still restrictions and laws that apply. And what that means is our unit does have locked doors. Patients can't come and go as they please. And if they consent to voluntary psychiatric care and then, like, say the next morning decide, no, I would actually not like to be here, we are actually obligated to provide a level of assessment so that we can make sure that that's a safe process. So while, of course, if all of the treatment goals are met and the person truly does not need to be in the hospital, then we would work with the family, the patient, outpatient providers as needed to facilitate a speedy discharge. But it isn't as immediate as someone saying, I'd like to leave, and then us opening a door and letting them walk out. And so that's something I think it's good for parents and families to be aware of, especially just so that everybody can understand, because sometimes that idea of voluntary treatment feels like it's more restrictive than it can feel if you are on a voluntary psychiatric hold. Because often, the hospital team has up to 2 business days to evaluate the safety of the patient if they request to leave on a voluntary hold. And those 2 days may feel very long. But, in my experience, that doesn't take 2 business days necessarily. Usually it's the amount of time it takes to provide an appropriate assessment and make sure that the discharge is facilitated appropriately. So that's voluntary treatment. So if the minor refuses voluntary care, but they meet that medical necessity, so they have presented some level of danger to self, others, or that grave disability, then there's something called family-initiated treatment, which is that a parent or guardian can sign their youth into the hospital for psychiatric care for up to 30 days. It doesn't require the consent of the adolescent, but the teen has to meet that medical necessity before treatment can be initiated. And while it can be up to 30 days, really most of those fit hospitalizations are between 7 and 10 days. So that's something that if you're at the emergency room and voluntary care can't be found, you might want to ask if family-initiated treatment is an option. It is more restrictive than voluntary because the patient cannot request to leave, but the family can request to leave. And so there's kind of some different things that go along with that. And then the most restrictive option, of course, is involuntary treatment. And this would come into play if the teen refuses to consent to voluntary care, the family refuses fit care or doesn't want to access that for some reason. There's many reasons you may not want to do that, but the safety of the teen is at risk, and the mental health professionals assess whether it truly is something that should involve a system called the Involuntary Treatment Court or the designated crisis responders. Those are independent assessors that have to come in and assess someone for involuntary treatment. This is the most restrictive hospitalization option. It involves a court process. It's very unusual for teenagers, and here at Tacoma General, we see it very infrequently. Usually we can provide voluntary or family-initiated treatment as necessary. Ooh, and I'm talking too much, I always do. So once the legal status is determined, the emergency room facilitates the referral and transfer process to send the adolescent from whatever emergency room they're in to one of the units available to them. And I have a few tips down here that I consulted with my social work team on of families who are navigating this process you might want to think about. One is, if possible, have your teen sign a durable power of attorney for healthcare form before going to the emergency room and bring it with you. Those forms are easily available online, and in Washington State, you don't have to have them notarized. And it's just a really good thing to establish with the hospital when you get there. If your teen is willing to sign that, that would allow you to have a little bit more direct access for information. We do, and we'll talk about collaborating with families. We do a lot of it, but that is something that I would advise. And also bringing a list of your teen's medical and outpatient providers, and know that this is a long process sometimes. So sometimes it can take a few hours for a person to go to the emergency room and get transferred to a psychiatric hospital. Sometimes it can take a few days, and that's for thousands of reasons beyond any individual's control. But just know that that process sometimes does take some time. So that can be stressful for families in my experience. So I'm going to turn the next section over to Dr. Kellerman, our clinical psychologist.
Thank you. I am going to briefly go over a description of our unit, and then we'll talk more about the treatment we provide here and what we try to accomplish with teens while they're here. So we are part of Tacoma General Hospital. We're on their campus. Our unit is fairly new. It was just finished in 2016. We don't have an outside space, but we have a wall of windows that overlooks Wright Park, which is right next door to us. We usually have about 24 patients at a time, aged 13 to 17. And as Peggy mentioned, the average stay is 7 to 10 days. An important thing usually for teenagers to be aware of is they're not allowed to have electronics here, including phones, and there's no access to social media or the internet while they're here for them. So this is a picture of one of the rooms, one of the bedrooms. Kids have single person rooms, and we have 3 or 4 bathrooms available in the different parts of our unit. And the bathrooms are set up to be single use. So if kids have worries about sharing bathrooms or community bathrooms, they're structured to be one person using it at a time. We also have a gym, we have an art room, a dining room. We have rooms with special lighting and music that we call comfort rooms that kids can access if they would like to do that. So I'm going to spend more time talking about the goals of hospitalization because this is an area that can be confusing for patients and families, and therapists too often have misconceptions about what we might accomplish with their teenagers while teens are here. So we focus on safety and stabilization and getting kids out of the hospital and back to their community so they can engage in outpatient treatment. So there's misconceptions that are fairly common, that we might provide intensive therapy or that we might go deep into issues that are maybe related to trauma or longstanding suicidal ideation. We really don't do that. We see those as issues that are better addressed over time in outpatient therapy, or if needed in a more intensive facility, like maybe a CLIP facility, if that's what's called for. But by and large, our belief is that those things are best addressed in an outpatient setting when kids are back kind of in the real world and out of the artificial hospital environment. So one of the big goals we have is just keeping kids safe at a time when they're at high risk for harm. So all of our furniture, all of our features in our unit, faucets, door handles, writing utensils are all designed for safety. So this is a picture of like one of the faucets we have that can't be taken apart or used for harm in any way. So we're able to provide a level of safety that's really not reasonable for parents and families to try and provide. And as Peggy mentioned too, our unit is locked, so kids can't just come and go. They have to stay here until it's time for them to discharge. And as I mentioned, another goal is to have kids stay here, be as short as needed to accomplish our goals, because we do believe that most improvements are going to be made back in the real world, not in the hospital setting. We also connect teens and their families to resources outside of the hospital. So definitely if teens don't have a therapist when they enter the hospital, we connect them with an individual therapist or counseling appointment when they leave. They'll have that appointment set up. If needed, we'll also be sure there's someone to prescribe medications for them. And depending on things like where kids and families live, there might be other services available that we can help families access. And our last goal is to provide kids with an opportunity to learn coping skills. And most of our therapies are centered around cognitive behavioral strategies or DBT skills. That said, things like level of distress, being in the middle of a crisis, difficulty focusing, and motivation levels affect how much kids actually take in and how much they gain in terms of new coping skills. So in terms of how we teach those skills, they're primarily done in a group setting. So we have 2 to 4 groups that teenagers attend each day. There's creative arts therapy. So right now we have a music therapist and an art therapist. We have mental health education groups. And then we have groups that focus on leisure skills where kids practice using leisure skills that don't involve electronics. This is an example schedule. So another just side benefit of being in the hospital is that often teenagers, when they come here, their sleep schedule has been very out of sync. So here we have really strict guidelines. We expect kids to be up and ready for breakfast at 9:15, and then they're in their rooms with lights out at 10. So it can be helpful in reestablishing a healthy sleep cycle, as well as getting kids back in a routine for eating meals, being active and interacting with other teenagers too. And other services kids get each day is every day they meet with their psychiatrist or psychiatric ARNP. We don't offer individual therapy per se, but if there's a need for that, usually this is where that's provided with the psychiatrist or psychiatric ARNP. Kids check in with a nurse twice daily, and the nurse goes over their symptom level with them and just checks in on a variety of risk factors as well as how they're doing overall. We have mental health technicians. These folks have, most of them have bachelor's degrees or equivalent work experience. They're with kids all the time, and they're always available for support, for coaching. And then there's a variety of different activities that are just available on the unit if teenagers want to use those. So workbooks, things to read, worksheets, and the like. And I am going to hand it over to our medical director, Dr. Luciano.
Hello. That's okay. We're just swapping out seats here. So in terms of considering medications for kids that enter here, before I go into that, I just also want to reiterate that to all the services that we talked about, we have a daily team meeting, which where we discuss each and every patient and their functioning and their presentation on a daily basis. And all multidisciplinary team members are in that meeting. And, so we keep up to date with every patient every day. So for medication consideration, I wanted to make a point of saying that the initial assessment for the child begins even before we see the patient the morning after they arrive at night. So the providers generally will review the emergency department report. They will also review any information in old charts that are available through the Care Everywhere portal, which gives us access to their previous treatments, and also the PDMB portal, which gives us access to a record of what kind of medications patients have been on in the past. So armed with all that information, we then see the child the next day. We have a thorough interview, and following that, the providers generally make outreach efforts to reach the parents, to reach the outpatient care providers, and get even more collateral information that the patient themselves may not be able to provide. This will also gives us a chance to see how other people in the patient's lives have observed them to be prior to this crisis. And it helps us to form an opinion of, what is the degree of dysfunction that resulted in the hospitalization. So once that is done, then we reach out to the parents and as well as the patient and inform them of the primary impression formed, the likely diagnosis that can be applied to the patient in question, and then also the treatment plan. And when we talk about treatment plan, we also review not only the medications, but also what kind of therapy would be useful maybe going forward, as well as what are the things that the child can focus on while they're on the unit. So once medication is seen to be indicated, then we review the options of which medications will be used, and psychoeducation is provided both to the patient as well as to the families regarding the options of medication choices, indications, dosing strategies, as well as the side effects, and review all those with both the patient and families before we go ahead with the treatment. So there's always an effort to collaborate with patient, family, and the outpatient teams regarding the planned treatment. And as much as possible, before I go on to the next point, so parents are all, when it's the first hospitalization and if the degree of functioning is affected to the point where it's necessary to consider medication intervention, there is always nervousness on the part of parents, which is understandable, very normal. So we really go through with the parents in detail what can be expected, and there are many questions about how long patients need to be on the medication, whether they're addictive or not. And these are all questions that we try and answer as much as possible when parents need that information. So on our unit, as much as possible, we avoid the use of controlled substances such as benzodiazepines like Ativan for treatment of anxiety. And because we have other options that can be used without, leading to that possibility of addiction problems, right? So such as Visceral, which is hydroxyzine, can be used and for anxiety. And therefore, when you see any kind of benzodiazepine that's being used, it will be only in the very rare occasion that patient is very agitated, and this happens generally in patients that are psychotic. And so In those cases, if they're agitated to the point of where they're going to be a danger to themselves or others and might need emergency medication to help them calm down, then we might use things like Ativan, which is lorazepam, or benzodiazepine. And the other medication that we might use, kids that do have ADHD symptoms and have been on stimulant medications, we will either continue them if it's effective. If not, then we will reconsider that. I'm only bringing this up here because stimulant medications are also partly addictive in nature, and also they're considered part of the controlled substances. And again, all medication use adjustments, trials are done in collaboration with the families, so that the families are always aware of what's going to be added or taken away from the medication. This, of course, is with the permission of the patients, because as we know, teenagers in Washington State are allowed to make decisions regarding their mental health treatment. And almost, I would say about 98, maybe even 99% of patients always ultimately agree to have parents involved in the treatment, because as we point out to them, the involvement of parents and parents being on board will only increase the success of their treatment in terms of being compliant, in terms of being consistent. Periodic updates of any changes that are made, or if patients develop any kind of side effects to medications, are always notified. Parents are always notified about that, so the parents are aware of every change that occurs. We make very measured and thoughtful adjustments when patients come in on different medications that don't appear to be helpful or that seem to be no longer useful. The goals for treatment and that, sorry, I didn't see what this is, but yeah. I guess the goal for treatment is to make sure that there is not too much of polypharmacy going on, that patients are getting medications that are specifically indicated for their symptoms and that are absolutely necessary. So we're not going to be treating every symptom with the medication, but looking at the patient as a whole, and then using one medication to, as much as possible, using a medication that will help most of the symptoms that are presenting in the kid. And at discharge, there is always a discharge summary that goes out to the outpatient team, so that they are aware of what was used and what was changed and what was added, and as well as the rationale behind the changes or trials of medications, so that it's streamlined in terms of handing off the care with the medication use. Thank you.
Yeah, thank you so much. So we will turn the time over to the next presenters.
Thank you so much for that amazing overview. That was really helpful, even as a person who's worked in the emergency department for a long time and has made those referrals. It's really great to have that kind of overview of the program. There were some great questions that were in the chat box, and I will make sure to ask those during our Q&A. So if Peggy and Dr. Kellerman and Dr. Boutier will stick around, we'll ask some of those questions during Q&A. So next, I have the honor of introducing two of our next speakers, Sydney Doherty and Melissa Olsen, and they're going to be talking about Children's Long-Term Inpatient Program. CLIP is the most intensive inpatient psychiatric treatment available to Washington State residents ages 5 to 18. There are 5 programs and a total of 84 beds across Washington State. The programs are located in a secure and highly structured setting designed to assess, treat, and stabilize youth diagnosed with psychiatric and behavioral disorders. So I am so excited to introduce our two next speakers. First, we have Sydney Doherty, and she is the Children's System of Care Liaison with Coordinated Care. And just to give you a little bit of background about Sydney, she has been in the social service field for 20 years, with the majority of her career spent working with children and families in public child welfare. The last 2 years of her career have been at Coordinated Care Washington, where she functions as the CLIP liaison, supporting youth, families, and caseworkers in navigating the highest level of mental health services for youth in Washington State. Following Sydney's presentation, we will hear from Melissa Olsen, who is the Program Director for Pearl Youth Residents. Melissa graduated from the University of Puget Sound and has been with Comprehensive Life Resources since 2013 and Pearl Youth Residents since 2016. So thank you to Melissa and Sydney. You both are amazing partners with Kids Mental Health Pierce County, and excited to hear an overview about our Children's Long-Term Inpatient Program. So I will turn it over to you.
Thank you, Ashley. Can you see my screen fine on your end?
I can.
Okay, wonderful. So thank you for that introduction, and thank you for letting me be part of Kids Mental Health Pierce County. I was really excited yesterday to watch Pierce County Council meeting and see Ashley accept a proclamation for Pierce County to acknowledge May as Mental Health Awareness Month. So lots of great work being done, including webinars like this, where we get to come together and learn about some really complex systems. So we were just able to hear from the ABHU, who even in this field, I learned some things about from listening to them. And then we're going to talk a little bit about CLIP and how it intersects some with the work that the ABHU does, but as a whole how it works as a whole in the mental health community. So let's kind of start out with what is CLIP, and Ashley gave somewhat of an overview of this already, but it's Children's Long-Term Inpatient Program, and it's for youth 5 to 17 years old in the state of Washington. Any youth in the state of Washington can go. It is a state-run hospital, so if you don't have insurance, if you have private insurance, if you have Medicaid, and you're eligible, you potentially can get a bed at CLIP. So who is eligible? Children are admitted who have been diagnosed with a really serious psychiatric illness. So the ABHU was talking about some of the youth that they see there in their programming. We definitely see youth who have generally had several short-term crisis hospitalizations. It's not a one-size-fits-all, but generally we definitely see that there has been a history of short-term psychiatric treatment. The children may have a history of suicidal or self-injurious behaviors, intense aggression or sexualized behavior. I think we'll take a little moment to pinpoint around sexualized behavior. Oftentimes, CLIP does want more assessment around sexualized behavior. So it is not unusual for youth to get what's called a psychosexual evaluation that does a little more deeper dive into what their sexual reactivity may be about, best type of supervision that they need, if they're a threat towards other children, if so, are there requirements around what age children they should be, et cetera. So that can be something that if we're in the process of applying for CLIP, that we need to do a little bit more work around to just plant a seed there. They can have medical needs and co-occurring substance use. Melissa, who will be following up with information about Pearl Street, certainly has done great work with kids who have co-occurring substance use disorders. The children often have complex family and legal issues. Many times they are involved with the legal system, and in particular, oftentimes they are involved with DCYS and are in foster care. Coordinated Care manages the contracts for youth who are in foster care, and at any given time, we have about 30 to 40 youth who are in CLIP programming, many of whom are either in foster care or who are adopted through the foster care system. So certainly that complex family need falls into those youth who are in the foster care system. Also, youth can have co-occurring developmental disabilities. There's been kind of rumor, so to speak, that CLIP will not take youth who have developmental disabilities, but really a large population of youth at CLIP does have some level of developmental disability. It's not unusual for DDA to be participating in monthly staffing with the youth that are at CLIP. And in particular, there are a lot of youth on the spectrum who have mental health as their primary diagnosis, but also that co-occurring ASD diagnosis. So let's talk about how is CLIP accessed. And the ABHU spoke about this a little bit in terms of the Voluntary Treatment Act, and I'm going to get in the weeds a little bit on that. So there's the voluntary CLIP application, which we have a couple slides to go through because that process becomes more complicated. if we're going the voluntary route versus if a youth is on a 180-day Voluntary Treatment Act or a court order. And the ABHU indicated that it's not very common that you see that. And certainly in my experience for managing a CLIP caseload for the last couple of years, it's pretty rare that I have kids that are put on an Involuntary Treatment Act for 180 days. But what is it? It's a law that allows anyone age 13 and above in Washington to be in a psychiatric hospital, even if they don't consent, and potentially if their parents are also not consenting. It's overseen by the court, and a designated crisis responder will follow the youth, and they can file for an initial 120 hour or 5-day hold, a 14-day hold, or 180-day hold. This is where it differs from the adult side a little bit, because the adults also have a 90-day hold. So kids can go from 14 days straight to that 180-day hold. At that time, you basically get a green light, so to speak, for a CLIP bed. Oftentimes, like let's say the ABHU had a youth there and they were being followed by the DCR, they determined that they needed to be held for the 180-day. They would stay at the ABHU until a bed came up, open in CLIP, and then the youth would transfer from the ABHU to CLIP. So these are kids that you're seeing in that short-term crisis hospitalization stay and then transferring to a CLIP bed. We prefer it to happen quickly, but it doesn't always happen that way. And I'm sure ABHU can attest to sometimes having some pretty complex kids in their care that need that ultimate long-term care. Okay, so let's talk a little bit about the voluntary CLIP application. So I've kind of broken it down into 5 steps. And step 1 being contact your managed care organization. So if you're with Medicaid, then you should have a managed care organization. Coordinated care is one, and there I think are 3 others that are available in Pierce County, and I do have a slide that has their contact information. I saw that Ashley was going to put the PowerPoint on the Kids Mental Health website, so you don't have to jot this down quickly or anything like that to get the contact information. So you'll contact your MCO or your BHASO, who I also have a slide that has their information. So if you were to contact us, I'm going to talk with you about, is CLIP the appropriate service? And you've probably heard, if you're a community member or a community partner, you probably often hear that CLIP is very hard to get into. And it is in the sense that you have to exhaust resources in the community. So as mentioned before, it's the highest level of mental health treatment in the state, and there are limited beds, and we want to make sure the right children and youth are accessing it. So one of the first things that I'm going to do if I have contact with a family, a community member, a caseworker, is talk about what services have been in place and are there other services that we should try before going this route. I will always have contact with WISE at this time and hear what their thoughts are. So clinically, how have things been going with the family? Are you making progress? Is everyone participating? Sometimes at this stage, WISE is not involved, and it's almost 100% of the time hey, we need to stop and get WISE up and running before we have this conversation. It's not a rule that WISE is in place, but it's definitely a high level of outpatient service that we want to explore. Every now and then, we will still refer, even if WISE hasn't been involved, because if you're a foster youth, for example, who is going from place to place to place, no one will take placement of the foster youth because their behaviors are so extreme. They're going in and out of hospitals because of self-harm or homicidal ideation. There are times that we will bypass WISE intervention because things are so extreme, and there's been many, many services in place for many years that we will still kind of go ahead with the process. Okay, I guess I'm kind of going into step 2 already. So your first step is contacting your MCO or your BHASO. And then step 2, again, is we're gonna kind of talk about, do you meet that medical necessity? The other important step to recall for step 2 is that youth who are 13 and over do need to consent to going to CLIP. So at this point, I'm also going to want to know if your child or the youth on your caseload is over 13, are they in consent to going to CLIP, which will include me having a conversation with them and getting a signed document from them that they are consenting. The ABHU has available to them family-initiated treatment where parents can request that the youth be treated even if the youth is not in agreement. We do not have that available to us for CLIP. So let's say youth is in agreement, it sounds like it's appropriate to refer. The next step is going to a local committee review. So in Pierce County, they're held once a month, and there is a presentation form and supporting documents that are gathered and given to the committee. And at the committee, the family, the caseworker, the youth, if they choose, presents about what's been going on, the services they have tried, why they think they need CLIP, and the committee ultimately votes on whether or not they think an application should be sent to the state to apply to CLIP. The local committee sometimes will say they do not think it's time to apply to CLIP, and they'll have other recommendations for the family or the caseworker. At this step, at step 3, that you are able to appeal that decision. So the local committee can say, nope, we don't think it's a good idea, but the family or caseworker at that time has the ability to apply directly to the state anyway. And I'm always there to help process that with families or caseworkers if that's an appropriate thing to do, or if we should follow the recommendations from that local committee and see if we can stabilize in the community, because ultimately that's what our goal is. Okay, step 4, I'm getting ahead of myself again. So this is, again, just sort of recapping what I said in terms of the committee says, yes, we'll be working on sending the application off to the state. If they say no, we can appeal that. So step number 5 is putting the application together and sending it off to the state. And this looks simple in this just couple little bullet points here, but this can be quite a bit of work. One of the main things that can hold up at this point is the need for a psychiatric evaluation to be completed within 6 months, especially for youth who are in foster care and are kind of from place to place. It can be hard to get that documentation and that evaluation completed. If you are a parent or a community member working with a youth who you think may be heading towards CLIP, this is a piece that is never too soon to start in terms of getting a psychiatric evaluation started and medication management with a psychiatrist or psychiatric ARNP. So here, again, that's part of the application. You get the application, which is, I think, a 9-page document, and the other supporting documents that go with it. We send it to the state. The state then reviews it, and they determine whether or not a youth is accepted and placed on a wait list, or whether or not the application is denied. Ultimately, if the application is denied, you can't appeal at this point. However, you can reapply later. It's not like if you are told February, nope, you're denied, and 6 months later things have really increased and are going poorly, we can still apply again. For youth that are approved, you're put on a wait list at that time. And depending on the program, which Melissa is going to talk more about the different programs, we are looking at a couple months up to sometimes 6 months for child study and treatment. So there's a lot of work that still continues to be done in this approved time between when the application is approved and a bed comes up. To give a little context, we had a youth approved to go to CLIP at the local committee not too long ago, and Comprehensive Life Resources, their WISE team, was doing some really great work with that youth. Ultimately, they were able to be reunified with their parents. They're doing so well that we no longer need the CLIP bed, which is always great. It's always a celebration anytime kids can stay in the community. But that just gives you a little example of there's still a lot of really good work going in at that time, and we are always trying to keep kids out of hospitals, whether it's short-term crisis hospitalization or long-term hospitalization. We really believe that kids are best served in the community with intensive service providers when they need it. acknowledging that sometimes youth do rise to that level where they need that high level of care, and we're here to support that process when needed. Before I kind of hand over to Melissa here in a bit, I do want to add that I will always give my clinical perspective on whether or not I think it's appropriate to apply for CLIP, but if a family or caseworker, if I think maybe there's things that still need to be done in the community, but the family or caseworker still wants to pursue the process, I still will help assist with the process and making sure that they have access to care. I think that is that. This is the contact for Pierce County. Again, Ashley will be putting this on the website, so you do not need to remember all of this. And then I'm going to go ahead and hand over to Melissa, who I have the pleasure of working with weekly, sometimes daily, it seems like, with kids that are in her program. So I will hand it over to Melissa.
Thanks, Sydney. And I will prompt you. Thank you for guiding the PowerPoint here. So a brief overview of the different CLIP programs that are in existence in Washington. I won't get into the nitty-gritty about all of them, just Pearl, because of course I work at Pearl. So there's a CLIP program run by Navos up in Burien. It's called Sunstone. Two Rivers Landing is in Yakima. Tamarack is in Spokane. Oh no, I lost my PowerPoint. CSTC is in Lakewood. It's kind of our sister program here locally. And then Pearl is here in Tacoma. There we go, I see it again. So if we want to go to the next slide, Pearl Youth Residence is where I work. It's part of Comprehensive Life Resources, which is a nonprofit here in Pierce County. That's where I started as an intern, actually. Worked as a therapist across schools and in their outpatient programs, and then came over to Pearl as a therapist and a clinical supervisor, and I've stuck around. I really found my calling here. So Pearl opened in 1985. I believe that they started as an 11-bed facility, and we expanded to, by the time we left that building, a 14-bed facility. We serve youth age 12 to 17.9, I usually say. So at 18, we usually are moving forward with a discharge plan back to the community. We are similar to the ABHU, a secure and locked facility. We've kind of already talked about who CLIP serves, so I don't have to get into that a whole lot, but kids come to us both through the voluntary and involuntary process. A lot of times what we see is kids that come in on an involuntary court order, oftentimes will sign themselves in to complete treatment. So they'll move from voluntary status, involuntary status to a voluntary status. What our program is designed to do is provide the most secure setting, highest level of care in the state other than acute hospitalization, and work with the residents and the families to build their skills here, then practice through outings, which unfortunately due to COVID has really, it's really restricted what we've been able to do in the community. But some of the things that we typically have done are a lot of hikes. We've done a camping trip. We go to Dorky's here in Tacoma and play at the arcade. We'll go to the dollar store, other grocery stores, even to just practice those practical life skills, being out in the community and getting some tasks done. We've also done, I'll get into this a little bit later, but equine therapy in Olympia. And we've done, when we were at our old building, we were right across the street from the YMCA. So we really utilized their services for dance classes, gymnastics, swimming, those kinds of things. Unfortunately, for over a year now, we haven't been able to access that, but some really great activities in the community to practice those skills. Ultimately, then kids will go on day passes and home visits with their families or their guardians or extended family to practice without us, and eventually overnight as well at their discharge location, wherever that may be, to practice their skills without us there. The typical length of stay here at Pearl is 6 to 9 months. The voluntary certification goes for 6 months. Same with the involuntary court order. They're both for 180 days. So at the end of that time, as I mentioned with the involuntary residents, they'll either sign in or discharge. At times we do also consider an LRA, a least restrictive alternative. It's an additional court order at discharge. And then at the end of a voluntary application or a voluntary certification process, we have to apply with CLIP to request more time if that's deemed necessary by the treatment team, the family, and the community. I've mentioned this a little bit through these bullet points, but Pearl did just move and expand significantly. So we moved from a 14-bed facility and like 3,000 usable square feet to a 27-bed facility and like 30,000 square feet. So we're really proud of our new space. We have 3 different units and a designated recreation room, a designated dining room, big mill use for group treatments, a big courtyard, actual office spaces for our staff. So it's been a great move. We moved in August of 2020. So we're coming up on 9 months here in this new building, and it's been a great move for us and really good for our kids as well. Ready for the next slide here. I just wanted to talk a little bit about our multidisciplinary team, both internal to Pearl and external. So this first slide talks a little bit about who we are at Pearl. So our multidisciplinary team typically consists of one provider. So that's a child psychiatrist, a developmental pediatrician, or an ARNP. Those are our 3 fellows that work with us. And these are the folks that manage medication, provide the diagnoses, and then any kind of referrals for specialty care. We have 24/7 nursing that consists of LPNs and RNs. Our case managers, they do care coordination from before admission to after discharge. So that's making sure that all the players that are involved are staying in close communication with each other, that we're moving through treatment and being able to track progress. They're also resource management, so making sure that kids are signed up for school, that they are getting the specialty care that they may need if they need to work with an OT or a SUD therapist or an SAY therapist. They're the ones coordinating with those individuals. The individual and family therapists are trained in all different modalities, evidence-based practices, collaborative problem solving, trauma-focused cognitive behavioral therapy, DBT, motivational interviewing, EMDR, family systems theory. I have DBT on there twice, don't I? So we at Pearl, we really do emphasize the collaborative problem solving approach as a whole program, but we do also have therapists that are more specialty trained in some of these areas to provide a concentration in whatever a la carte item might fit best. Our recreation therapists, we have 3 full-time rec therapists, which is awesome for us. When I first came to Pearl, we had like 1 part-time, kind of half-time rec therapist. So we actually have a rec department now, which is really awesome. They've been able to make connections with community partners, some bookstores. There's a Magic the Gathering store, I think, that's donated a bunch of materials for us. We've gotten bike donations. They're the ones that coordinate our camping trip. But they're not just all about activities. They also provide one-on-one treatment, assessments, making sure that we're really honing in on what leisure activities are going to be the most beneficial for the residents. While they keep them busy and do lots of fun activities, they also do a lot of processing, art therapy, yoga, more motivational interviewing kind of directed activities as well. We have certified peer counselors. We have 2 youth peers and then 1 family advocate that works with our parents. They're a big asset to our team, being able to pull from their lived experience and help kids move through based on their own experiences and what's helped them in treatment. And then last but certainly not least, the heart and soul of our program really is our residential counselors. They are 24/7, as are the nurses, and they provide that live feedback in the moment when things are going well and when things are maybe not going so well, and help guide kids through interactions and more positive coping skills. The next slide focuses more on a little bit of the team members that are outside of Pearl. Our SUD treatment providers actually are through our parent agency, Comprehensive Life Resources, their Reinvent Recovery program, which is really great because we can connect more with them and do more consultations. So we meet monthly and then on an as needed basis for the kids that come in with either a history of substance use or disclose that throughout treatment. So the SUD treatment providers provide individual and group SUD treatment for us. The school is provided through Tacoma Public School District. It's here on site. We have 2 huge and beautiful classrooms. And we have two teachers and two paraeducators, one pair for each classroom, and they are phenomenal. We've really developed a very strong relationship with the Tacoma Public School District. Fortunately, they were able to not only get us 4 days in-person learning, even through COVID, but also advocated for us to have school year round. So that can really help with credit retrieval, with consistency and schedules. They're doing after school activities. So it's really helping the kids progress in their educational goals as well as their mental health goals. Of course, the youth and family are included in the treatment team. We really want to make sure their voice is heard throughout the treatment plan and throughout treatment and discharge planning. The MCOs, of course, as Sydney kind of talked about, are always part of the team, and the CFTMs that we do each month to track progress and always be talking about discharge planning. As the discharge date approaches, we make sure to enroll kids or have them apply for the WISE services in their home community, wherever that may be. Whenever we can have WISE involved throughout length of stay is always preferred. The earlier, the better, to be able to coordinate care and transition smoothly once they're in their home community. The other resources identified as from the treatment team, that may consist of other specialty care. So we have some kids that are involved in the DDA. We have some kids that are have specialty services through like an ABA therapist. We work with Karen Feller, which some of you may be familiar with, but she is a SAY provider. So she provides services for kids with sexually aggressive behaviors. We do consult with her, but sometimes she's also assigned to some of our kids. Trying to think of other specialty care that we may work with that's not necessarily medical, but our kids do go to the dentist, the eye doctor, primary care doctor while they're with us. So some things may come up through their appointments, like an endocrinologist or other specialty care for medical reasons. So that kind of rounds out our treatment team. We meet monthly as a whole to track progress and talk about discharge planning. And then the internal PYR team meets on a weekly basis to staff every case to make sure we're all working collaboratively and a unified front through all our different services. So that's all I got for you guys. I'll turn it over maybe to Ashley now.
Well, that was amazing. Thank you so much for that overview of CLIP. I'm going to invite all of our panelists for today to join us. We've had some great questions that have come up in the chat box, as well as participants asked questions during the registration. And so I also just want to direct all of our participants to the Kids Mental Health Pierce County website. We do have links on CLIP. We have links to the ABHU. We also have links on family-initiated treatment as well. And so those will be great additional resources that you can access through the Kids Mental Health Pierce County website. So I just wanted to go through the chat box and some of the questions that have come up. And this might be a good question, well, for both CLIP and the ABHU. Has COVID impacted the time limit to get the referral for hospitalization?
So this
As
is-
far as, oh, sorry, go ahead.
This is Sydney. I can speak in terms of CLIP. The referral process does not take longer, but we have seen an increase in the wait list for a bed. So certainly the wait list had been pretty bogged down for a while. It is moving a little bit quicker. Melissa kind of indicated that they have expanded their programming, and so we have seen some movement recently, but certainly COVID did impact that CLIP wait list.
Thank you.
So as far as the inpatient hospitalizations are concerned, over this last year, our unit has had a record full census, and we are filling beds about 2 days in advance. So there's waiting list. So I would definitely say that the COVID has increased the frequency of mood symptoms as well as suicidal ideations in kids, so that we are having a record number of referrals from various emergency rooms And most of the inpatient units are really getting a lot of referrals so that there is an increase in the waiting list, you know. It takes a couple of days sometimes for kids to get a bed. And it's a statewide problem that's at the moment they're trying to address that at the state level.
Absolutely. And I think that kind of feeds a bit into the second question is, are there similar services for children under the age of 13? And do you see this as a particular need for youth in Pierce County? I will start in answering some of this. You know, I think when we look at services in Pierce County, it's really important to consider that whole continuum of care and looking at services from prevention all the way through acute intervention, crisis intervention, and then recovery and reintegration. And so both inpatient hospitalization and children's long-term inpatient treatment are two of those services that are kind of at the end of the spectrum of you're looking at acute intervention, crisis intervention, and recovery and reintegration. And so, you know, when we see kids that are coming in, we always want to look at that less restrictive options. What resources are available within that natural family support, and what resources are available within the community that can keep kids safe in their communities. And so for a lot of times with kids under the age of 13, we look at some of those less restrictive options that could include referrals to our youth mobile crisis services with Catholic Community Services, our referral to wraparound with intensive services, our WISE program, all kind of depending on what the presentation is and what those safety needs are. Unfortunately, if we are looking at that higher level of care for those kids that need that level of acute intervention, crisis intervention, that need inpatient hospitalization, there's very few beds in Washington State for kids that are under 13. So you will typically be referred out of Pierce County if you needed that level of service within a brief stabilization unit, such as the ABHU or Fairfax. So there's not a lot of beds for kids under the age of 13. I don't know if any of our panelists want to add to that as well.
I think you hit the nail on the head there. You know, I think limited beds and resources for all youth, but in particular younger kids. Seattle Children's is the only hospital available for, is it under age 12 for short-term crisis? And then CLIP just has one program available for the really tiny kids who are 5 to 11.
And I think Dr. Boutier's talked about some of the top contributing risk factors for mental health issues that we've seen. Definitely seeing a high level of suicidal ideation, depressive symptoms that are coming through the emergency department. There was a CLIP specific question. What is the approximate time frame that it takes to get from step 1 to step 5 in that process?
So really depends. I will say that I have had reach out from a parent to having the local committee meeting to having an application turned into the state within a 2-week time frame. I'd say that's probably the quickest it's ever been, and probably more looking at a 30-day time frame to get the application into the state. The thing that makes it a little more difficult to gauge is that what the wait list will be at the state. So the state will, if they review an application, it's only certified or approved for 30 days. So the state doesn't like to, let's say we send an application today, they wouldn't want to review it and approve it today knowing that there's not going to be a bed that opens up in 30 days. And so therefore they would have to re-look at the application, recertify it. So they kind of put the application in a holding pattern and wait till when there's going to be a bed opening up, review the application, certify it with the idea that that youth will move into a bed within a 30-day period of time. So again, the different programs have different wait lists, and they vary. So difficult to gauge exactly after a complete application is with the state how long the wait is, but usually at least 2 months and up to 6 months for child study and treatment.
Thank you. And it looks like this is a question for the ABHU. If a youth gets to the end of their 7 to 10 days at the Adolescent Mental Health Hospital, but they need a longer inpatient stay, what are the next steps?
Yeah, usually the 7 to 10 days is really just an average. So that would be something that would be based on the reason that a person may need longer than the 7 to 10. But we certainly do have folks that for one reason or another stay here longer than that and shorter than that time frame. That is just our average.
So the numbers are just there as a guideline, but the real decision on how long a patient needs to stay is really based on clinical needs. And if they need longer term, then of course there's the whole other process that we go through in terms of applying for a residential or CLIP facility. You know, and if they're fitted, they can be kept up to 30 days if the parent also is in agreement for the need for treatment and if the recommendation is there. But yeah, the average length of stay is 5 to 8 is an average figure so that parents can have a sense of time. But if the patients are unable to progress, then based on their clinical needs, we can extend that stay. So we have had patients that stay for more than 10 days as well. It's not very often, but it can happen, yes.
Thank you. And I think that goes to one of the questions I see in the questions box about what happens when there is a gap where a kid may, you know, benefit from being referred to a program like CLIP from a stabilization unit, but there's not an available bed. So the question is, are there other options to get kids into longer term care? And I think you spoke to that a bit about looking at other residential treatment options, just really depending on what that youth's insurance coverage is and their presentation. Another question that we received is, would you say that most kids being released from the ABHU and CLIP beds are first referred to WISE or directly to outpatient services like Greater Lakes or Comprehensive Life Resources? And then the second piece of that would be, what would guide your decision of making a WISE versus a outpatient referral upon discharge from these programs?
Yeah, I think we do refer many patients to WISE when coming out of the ABHU. I think the things that go into that decision-making are kind of the package of services that WISE entails and what may have gone awry that would, you know, necessitate the need for hospitalization. So if it's something that the person has been engaged in outpatient therapy and has been in the mental health system and that level of care is not meeting their needs, we may talk to folks about what WISE entails, because there are family supports there, a lot of extra things. If it's the case that, you know, the individual's needs arose and there wasn't therapy in place, we may start with therapy, but that is really a collaborative conversation about what supports are really going to best fit the needs of the family and the patient. Because WISE is an intensive program and, you know, it's not for everybody. So that's a conversation that we have about are the things that are in need of support aligned with what WISE can provide.
Thank you.
I would add, just from CLIP perspective, all of the kids leaving CLIP do qualify for WISE level services, and we tend to think that it's a really important step down. I talk about going from 60 miles an hour to maybe 15 miles an hour with a regular outpatient team, but involving WISE could be more close to like a 45 mile an hour or 30 mile an hour step down. So I think that's really important, something we stress with kids and families is really engaging with your WISE team, which also helps to have them involved at least 30 days before discharge.
Thank you. And I think this is a question for both Melissa and our team at ABHU. Are there any volunteer opportunities for community members within your facilities?
That's a great question. Right now, I would say no. Unfortunately, with COVID, we're really trying to limit the amount of traffic in and out of our facility. We don't really allow visitors. And it's not always as easy as I think it was when I first came to Pearl, where we would welcome volunteers, just making sure we had a confidentiality agreement. But now with the growth of our program and the growth of our agency, it's quite the process going through like a business agreement or type of contract. So it is possible. It just needs a really defined intent and purpose. Some of the volunteers that we've had are yoga instructors. We've had some folks come in and do like a sewing group or an art group. We also had a craniosacral therapist come and work with our kids, which was really interesting too. She did that on a voluntary basis. So it does happen. It's just not as quick and simple as it has been in the past.
Sure.
I think at the ABHU, we used to have a pet therapist that was a volunteer in the past before the times of COVID. Since COVID, we have not had any opportunities for extra people to get into the unit. But once COVID is over, it's something we can always look into.
All right. Well, maybe two more questions. I'm wondering if you could speak about how culture is addressed in your programming and treatment planning with youth that are admitted into your programs.
So just in my experience in the last 2 years, almost 2 years that I've been here, we had one child that was an illegal immigrant that was undocumented, spoke only Spanish, which was I think a little bit different from the usual Spanish that's spoken here. So we were able to identify a in-person translator that spoke that same type of language, and we were able to provide him with that comfort of having somebody that he could understand. Whilst in the beginning, when we were not able to get that person, we were using video translations and trying to use images to communicate with him. He ended up staying with us for quite some time. And so I think using that translator, as well as trying to understand all the trauma he had been through during his arduous journey from, I forget which South American country he had come from, and he ended up here. So that is there, and understanding the culture from which he came, where, you know, at a young age, they were talking about very heterosexual stuff, and understanding that that was what he was exposed to in the place that he came from. And so, you know, not coming down on him really hard about inappropriate conversations, but trying to explain to him within the, you know, parameters of living here and being on the unit, how those kinds of conversations would be difficult to allow. And ultimately, he was comfortable and was able to communicate with most of the staff, even learned enough English to really have a fairly good conversation where he could express his needs, etc. And we had another immigrant that was adopted and brought from one of the Eastern European countries, and also had a huge language barrier, but we were able to locate a staff that could speak that language, and we were able to ensure that this person was available for the patient to be able to communicate their needs. And we tried to understand, you know, the background that she came from and the family dynamics that was leading to her hospitalization with her adoptive family. I think some of that
Yeah.
is, yeah.
And I think that one of the things I've observed also is that because we try to engage with families as much as possible, that's part of the conversation, especially around, it seems, medication. And if medication intervention is not something that isn't in line with the family's culture and their cultural background, that's a conversation that we have about alternatives to that, and other kinds of interventions that might be more culturally appropriate, if that's the case.
Yeah, I would second for Pearl what the ABHU does in their strategies. We try to make sure that staff do a lot of prep to understand culture as the youth and family come into care, and make sure that their voice is particularly represented throughout treatment. We also try to work with families and communities to make sure that if they have connections with either their home community or if there's another provider here closer, that they can attend events or services or whatever fits their needs here in the community, especially not considering the COVID world we live in now, but making sure they can go on lots of passes to stay involved in those same activities that contribute to their culture and overall their recovery process.
Thank you both. Just one last question. What financial options are available for families who don't qualify for Medicaid but have inadequate insurance coverage for youth mental health treatment?
So sorry, go. On an inpatient basis, we do have, certainly we could connect families with our financial navigators to see if, because I'm trying to think of the name of the program. It's charitable care through the Washington State Hospital Association, would apply to admission to the adolescent unit. And we don't bar people from entry due to lack of financial resources. So if folks have no insurance coverage, that is something that we help resolve with them. And so it's not a barrier to accessing our care if it's necessary. And so, you know, I don't know the exact particulars of it, but it is something that certainly a conversation with our financial navigators might be helpful for.
Thank you. Sydney, were you going to make a comment?
I was just going to say in terms of CLIP, that there certainly can be private insurance, that maybe there would traditionally be some out-of-pocket expense or deductible that would not apply for going to CLIP. It is youth that go to CLIP get state dollars or Medicaid dollars that it's funded through. And same with if you do not have insurance, that is also not going to prevent you from applying for CLIP. And again, you would contact the BHASO in those scenarios, and their contact information was on one of the slides.
Well, thank you. And I want to thank all of our panelists today, Dr. Kellerman, Dr. Boutier, Peggy from our Adolescent Behavioral Health Unit, Melissa and Sydney for your amazing overview of CLIP. I want to thank you guys for being available for these questions and answers, and all of our participants. I hope that we can continue to have these conversations and overview of the services available. I think it's so important for our community to know how these resources are accessed and what meets criteria for that. I'm sure we can continue this conversation many more times and learn something new each time. So thank you to our panelists and our participants for participating in today's webinar. I did want to just take a brief moment to share our upcoming webinars. We're really excited that May is Mental Health Awareness Month, and our theme for the month is Tools to Thrive. So we really want to focus on building resiliency through community connections. And so we have 4 scheduled webinars that really will be highlighting on how to build that resiliency, also suicide prevention, secondary trauma and self-care, particularly for our behavioral health providers in the community, and understanding the impact of trauma on childhood development. We have several other resources for Mental Health Awareness Month on our website, kidsmentalhealthpiercecounty.org. So again, thank you to all for participating today. This webinar was recorded, and so we hope to have the recording and all the materials on the website next week for your review. We'll also send out a follow-up email. So again, thank you to all of my panelists. Thank you to all of our participants. And if you have any questions, please feel free to reach out to me, Ashley Mangum, the project manager, and you can reach me through our website, www.kidsmentalhealthpiercecounty.org. Thank you and have a great day.
Thank you very much.
Thank you.